I'm a clinical hematologist and oncologist, mostly focusing on non-malignant or so-called classical hematology. I'm at the University of California, Davis. And more relevant to this, I've been caring for patients with sickle cell disease as one of my primary clinical foci for like over 30 years. And about the same time, that's also been my research focus. So both done clinical investigation and epidemiological investigation in sickle cell disease. So the background for this is really trying to fill a gap in information about the rates of stroke, which include ischemic stroke, so lack of blood supply to the brain, hemorrhagic stroke or bleeding, and then transient ischemic attacks in our patients with sickle cell disease. And much of the information has to do with children in this area, less so for adults. There's been some investigations, but not so much. And since I'm an adult hematologist, and our group was just curious as to the epidemiology of stroke in adults, because we've certainly seen it in my practice, and then the collaborators from at that time University of Washington, the first author Busola moved on to the University of Pittsburgh for her first academic appointment. So we've taken advantage of a large cohort that we put together using discharge data in California, which is rather unique because we were able to get the information from this longitudinal data set from 1991 to 2019 that allows us to track individual patients as they are admitted to emergency departments or inpatients in California. And so we can look at using diagnostic codes and procedure codes, some of the complications that they've had, as well as the procedures that they've had throughout, sometimes spanning 25 years or so for an individual. And we do this in a very privacy protected way. The state is able to create basically an encrypted form of a social security number, which allows us to follow a patient, their data, at least their admission data, throughout years in different facilities, but doesn't allow us to identify who that person is. I guess the first, again, from my standpoint, being an adult hematologist, is that the rates of stroke as our patients now age into the 40s, 50s, and 60s is higher than in children. And when I was training as a hematologist many years ago, I think what we had emphasized was that strokes happen in children with a maybe peak age around 11 or 12 as far as the rates of stroke. And I think at that time that was true because there are not many patients lived into the age bands, age groups that I mentioned. And so now that the pediatricians do such a good job of bringing patients with sickle cell disease into adulthood, and we now take care of them on the adult side, they have accumulating complications and organ damage that we're now seeing in those patients who are older. And I think part of the motivation for this is, in my own practice, I have had patients in their 30s and 40s who present with stroke, and just not knowing how frequently it is. So one is just awareness that strokes continues to be, a risk for stroke into adulthood in patients with sickle cell disease. I guess the second one is that those traditional risk factors, we use that term in adult medicine, of high blood pressure, high lipids, not so much diabetes, because we didn't see that. It's not as common in sickle cell patients as maybe the general population, but essentially those things that we worry about as a general internist, in my case, to try to screen for and modify in the general population, that we should pay attention to those in sickle cell patients too, that if they have high blood pressure, to try to treat it aggressively as we would, perhaps even more aggressively than somebody in the general population, because I consider sickle cell disease an additional risk factor for vascular events, just like diabetes would. So I guess the message would be to, one, identify with people with those modifiable risk factors, and secondarily to treat them as you would in the general population, and perhaps even more aggressively, perhaps as you would in somebody with multiple risk factors for stroke or a heart attack. In the general population, say they have diabetes and hypertension and high lipids, to treat them in the same way for risk modification to reduce their risk of having a stroke. And I guess the third one would be that even in children, despite an initial decrease in the rate of stroke, at least in California, which probably was because people saw the STOP study, which showed that you could identify high-risk children and with transfusion decrease the risk of stroke. There has been an increase again over the last decade of stroke rates even in children. And so it brings to for this notion of implementation and implementation science, which is the realization that many things that have been shown to be effective in these big studies are oftentimes not, I don't want to use the word accepted, the proper word is incorporated or fully implemented into general practice. And so there are many potential barriers or challenges in implementing things that have been shown to be effective in the practice. And so the field of implementation science tries to identify and overcome these barriers. And so because we, as I just mentioned, I think we know how to reduce stroke risk based on those risk factors, and we know how to reduce stroke risk in children too, based on the STOP study. It's paying attention to, well, why perhaps aren't people following the guidelines?